Welcome to another Puscast. This one covering April 1st through 15th, 2015. As always, this is brought to you by Pusware LLC, the website of which can be found at edgydoc.com, where you can find links to my growing multimedia empire of books and apps and podcasts. But you're not here for the intro, you're here for the medical literature. Let's get to it, shall we? And if you're interested, and there's no reason you shouldn't be, the SMAC conference, Social Media and Critical Care, will be held in June 23rd through 26th in Chicago. I will be giving several talks at the conference. You can find out more at smacc.net.au. Me alone should be worth the price of admission. And now we will move on to the medical literature. Let's start the day with some zoster, which I've seen a bit of in the hospital lately. First is epidemiologic study that showed that with the use of HAART, the risk of zoster has declined markedly in the HIV population, but it remains 3 times higher than the general population. So it is still a risk to get reactivation of your herpes zoster if you have HIV. Now, what's the big problem with HIV these days? Well, it's vascular disease, and it's the control of sugars and cholesterol, some of which are exacerbated by highly active antiretroviral therapy, which gets intriguing because there's a study out of Asia that looks at the risk of zoster in patients on statins. So they looked at 50,000 people in the statin group and 50,000 people in the non-statin group, and they found that statins increase the risk of getting zoster by about 21%. Now, it's a small risk to a slightly larger risk. But still, it's interesting that the immunomodulatory effects of statins, which may or may not be beneficial in things like sepsis and community-acquired pneumonia, may increase your risk for zoster. And if you have HIV and you're on statins, maybe that will increase your risk even a little bit more. PML alert. There's a medicine called dimethyl fumarate. It's used predominantly for relapsing MS, and there was a patient who was also using it for her bad psoriasis. Both patients went on to develop PML as a consequence of the medication. One had a severe lymphocytopenia, but the patient with psoriasis did not. So we can add this to the list of drugs that potentially could be causing PML. There is now a long-acting form of DMF, which will make it more likely to be used. According to the Wikipedia, it's also used for necrobiosis lipoidica, granuloma annulare, and sarcoidosis. And it's used as a biocide in furniture or shoes to prevent growths of molds during transport or storage in a humid climate. Now, I think Tamiflu, oseltamivir, has a bad rap. And no, I'm not a drug company whore. I have never accepted anything from a pharmaceutical company in my entire career. I think this derives from the awful Cochrane reviews on Tamiflu. Well, not so much awful as profoundly biased. I've written about those extensively over at Science-Based Medicine. While in normal, healthy outpatients, Tamiflu only decreases the illness by about a day, in at-risk groups, it decreases both hospitalization and death and potentially the spread of disease. But it has a bad rap, and everybody thinks Tamiflu doesn't do anything. Not true. The consequences of this inappropriate bad rap that Tamiflu has is demonstrated in an article out of Tennessee, which found that people are doing a lousy job of giving Tamiflu for patients with influenza. And it didn't matter if they were sick or had high-risk conditions to predispose them to bad outcomes from influenza. They were lousy at giving oseltamivir to patients with influenza. There's a website called the Jenny McCarthy Body Count which has a running tally of deaths from vaccine-preventable illnesses. I think maybe we need to do a Cochrane review body count and show the number of influenza deaths in patients who did not take oseltamivir who should have. At least we have the vaccine, such as it is. This study looked at the benefits of vaccines in the diabetic in a meta-analysis and systematic review, and found that looks like in diabetic patients, the vaccine prevented all-cause hospitalization and hospitalization due to pneumonia, but did not, have an effect on influenza-like illness. However, as so often the case in these studies, it was GIGO, garbage in, garbage out, and they comment on the poor quality of the studies that went into the meta-analysis, which is so often the case. However, if you're a preponderance of data kind of guy, which I am, I think it's safe to say that influenza vaccine does have some effect, just like airbags do if you're in a high-speed collision. Might not be perfect, but it's better to have them than not. I have heard of honeymoon cystitis, which is a urinary tract infection after the beginning of sexual activity and presupposes that sexual activity starts with the honeymoon. There is an outdated concept. But I had not heard of the term honeymoon fever. There's a case report in the International Journal of Infectious Diseases of a couple returning from their honeymoon from Colombia to France. They both developed fevers, and she turned out to have leptospirosis. Maybe honeymoon fever is a French term, but it's the only reference I can find on the Googles or PubMed in a medical context. Mycoplasma resistance is becoming a big problem. I've talked a fair amount about Mycoplasma pneumoniae resistance. It's a big problem in Asia, much more than the United States, but all resistance is but an airplane flight away. Also gaining in resistance is Mycoplasma genitalium. This study is out of Australia, and they had a whopping 39% failure rate with azithromycin due to pre-existing azithromycin resistance. And they used moxifloxacin, which had a 12% failure rate. They, too, had pre-existing moxifloxacin resistance. What can you use then? Well, they have a drug down under called pristinamycin, which I'd not heard of. It is a cousin of Sinercid, which is available in the United States, albeit only intravenously. It looks like Sinercid may be a good drug against mycoplasma if you have failed more standard oral agents and resistance is an issue. Alternatively, you could take a plane to Melbourne and get some pristinamycin, which would be my option rather than taking Sinercid. I had my come to Jesus moment about the year 2000. I used to think that infections were somewhat the price we paid for medical care, and that hospital-acquired infections were part and parcel of the hospital. I now am convinced that almost every infection in the hospital is fundamentally preventable, although it's difficult at times to do, with the possible exception of catheter-related urinary tract infections. Once you get a catheter in your bladder, who knows? But everything else, surgical wound infections, staph bacteremias, line infections, surgical wound infections, are all virtually eradicatable. There's a nice review in Clinical Infectious Diseases called The Control of Methicillin-Resistant Staph aureus Bloodstream Infections in England. And they show so clearly that if you really give a rat's ass and you walk the walk and do all the things you need, a multi-pronged approach to MRSA, that you can drive your MRSA infections into the toilet. I don't know about your institution, but there's always one naysayer at the committee meetings who can't or won't accept that infections are almost always preventable. And if you do the right thing by your patient, the infections disappear. I recommend this particular article if you should have such a recalcitrant person in your hospital, although I doubt they will be amenable to data such as this. I have a vague memory that in the old days, when patients had weeks of subacute bacterial endocarditis, that if you did routine angiography, you would find asymptomatic cerebral aneurysms. In the era of acute endocarditis, that did not seem to be as common a problem. You'd see the occasional strokes, but I've seen 2 aneurysms that I can remember, confirmation bias here, in my 25-ish years of private practice infectious diseases. However, this study did routine CT angiography in 81 consecutive patients with left-sided endocarditis, and the results were quite interesting. A third had intracranial mycotic aneurysms. Of these, 15 of the 26 were clinically silent. Having strokes, both symptomatic and asymptomatic, is not uncommon with endocarditis, but I'm somewhat surprised at the frequency with which they found aneurysms in patients with acute endocarditis. These are predominantly Staph aureus in young people. The question is, should you do something about it or go looking? It is probably reasonable in a patient who's going to undergo valve replacement to get a cerebral angiogram before they get their anticoagulation. And it would definitely be interesting to see this study repeated. But it was done in the Netherlands, so it is a reasonable approach to extrapolating to the United States, for example. And as long as we're on the topic of cardiac disease, the magic of 16S ribosome has been applied to valves in patients with culture-negative endocarditis. And they looked at 370 cardiac valves. These were prosthetic valves. And they found Mycobacterium cheloniae on 5 and Mycobacterium lentiflavum on 1. 6 out of 370 cases of culture-negative prosthetic valve endocarditis were due to atypical mycobacterium, something to bear in mind in your next culture-negative case. And as long as you're operating on these patients, remember, the studies show, just recently out, March 2015, that if you're doing open heart on a diabetic, continuous postoperative infusion of insulin leads to less deep wound infections than a sliding scale. I think most people know the importance of glucose control to prevent postoperative wound infections, but here's one for sternal wounds, which are a disaster when they occur. Yay, I'm protected from infections. The article is Dermal Adipocytes Protect Against Invasive Staph aureus Skin Infections. Yay, go fat. Probably means that the Republican presidential candidates will not get a brain abscess. So what's the best treatment for community-acquired pneumonia? This study in the New England Journal of Medicine looked at the difference in outcomes between patients receiving beta-lactam monotherapy, ampicillin, amclavulanate, or third-generation cephalosporin, versus a beta-lactam macrolide combination or quinolone monotherapy. And patients were randomized in 4-month intervals to one regimen or another. The most common cause of infection was pneumococcus, which is 15-16%, followed by Haemophilus influenza. There was no difference in any of the regimens for any of the endpoints looked at. So it would appear that monotherapy with a beta-lactam is no better or no worse than a beta-lactam plus a macrolide. However, I would do one little caveat here. It's my understanding from the literature that the benefit of a macrolide is in patients who have pneumococcal bacteremia. Is the bacteremic patients who may benefit from combination therapy. And this was not, as I can tell, looked at in the study. But there are also definite issues with combination therapy, leads to more resistance, and macrolides kill the occasional patient with cardiac arrhythmias. I have always been skeptical about the issue of atypicals as a cause of pneumonia in addition to strep pneumoniae, and this study would also be indicative of that. We only get a Legionella, for example, about once a year in the Great Pacific Northwest. So a beta-lactam alone is probably sufficient for non-ICU patients with pneumonia. Of course, now we have to wait till the guidelines get changed for Medicare reimbursement, blah, 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 blah. We had a tornado here in the Great Pacific Northwest recently. Why should you care? Well, the causes of pneumonia are different following tornadoes than not. And someone actually went and looked at the microbiology of pneumonias in patients who have been exposed to tornadoes. And they get infections with things found in the soil. Aspergillus, Pseudomonas putida, Alkagenes xyloexidans, which I always mispronounce, and Burkholdia species. So you get weird things when you get pneumonia in association with tornadoes. Plus, of course, you know about mucor and skin disease as a result of flying trauma due to tornadoes. So next time you're trying to get to Oz, I think I would recommend taking a train rather than the usual tornado route. Even an hour can make a difference. This looked at the results of dropping altered mental status as a reason to get a CT before the lumbar puncture in patients presenting with bacterial meningitis. As a result of dropping that, patients got their antibiotics a mere 1.2 hours earlier, and they did better clinically. The sooner they got the antibiotics, the less likely they were to die. And they gave a 12.6% per hour increase in mortality with delaying antibiotics. So personally, I think if you think the patient has meningitis and you're going to send them off for a CAT scan first before the LP, because they have contraindications, perhaps like focal neurologic findings, I'd just give them the antibiotics. The sooner you get them in, the better. It's best to get an LP and then antibiotics, but the world is not perfect. But don't diddle around with a CAT scan in someone with suspected bacterial meningitis by withholding early antibiotics. By the way, the official Swedish guidelines for, quote, red flags to make you want to worry about a mass lesion are papilledema, focal neurologic signs, moderate to severe impairment of mental status, immunocompromised state, and new onset of seizures. Those are the usual guidelines that would make you want to do a CT before the LP, and they dropped the altered mental status part. And as a result, mortality went down because antibiotics got given sooner. Long-suffering house staff know that I routinely rant against antipyretic therapy in patients. Fevers are good for you. It's an important physiologic response to infection. And every study that has looked at the treatment of fevers in infected patients fails to show benefit and often shows poorer outcomes. This study looked at antipyretic therapy retrospectively in patients with sepsis. They found no benefit in reducing mortality risk. They did find that external cooling was harmful and that there was an increase in mortality in patients whose temperature was above 39 who received antipyretic therapy. Now, this was a retrospective analysis of 15,268 patients, but still, the data is consistent. There's no benefit in treating fever, and most of the data shows if there is an effect, it's an adverse effect. Fevers are good for you, with the caveat that you need to have the cardiopulmonary reserve to cope with the increased metabolic demands of fevers, and you don't want to be infarcting something. 3 quickies on sepsis. I will let my ICU colleagues deal with this one. But in this study, early goal-directed therapy did not help for septic shock. However, there is a retrospective study that showed that if you were on antiplatelet agents before admission, that your mortality for sepsis was down. It's also a benefit to be on antiplatelet agents if you are going to develop endocarditis. So if you're planning on getting strep endocarditis or urosepsis, I suggest that you get a little antiplatelet therapy first. That's the problem with these studies, is that if you don't have an indication for the medications, there's no reason to be taking them in a prophylactic reason for infection. And finally, as is always the case, in sepsis, if you put patients on the wrong antibiotics, they have increased mortality rate. And a significant number of patients receive inappropriate empiric antibiotics when they come in septic. In this study, it was 41% of patients, which is pretty impressive to know that you have an infection that's not amenable to vancomycin and zosyn, which is all anybody gets anymore when they hit the door. Naegleria seems to be showing up. It's gotten outside of its normal range of the south. There have been reports in Minnesota, which I've talked about, Kansas, and Indiana. Perhaps it's global warming. Warmer water will probably lead to Naegleria. This kid, unfortunately, died of Naegleria. Probably picked it up using a water slide in their backyard in Louisiana, and they looked at the water that supplied the house, and it had Naegleria in it. So the public water system, although treated in Louisiana, had a little Naegleria in it. Whether that's true in other publicly treated water systems is, of course, not known. But if you're going to be using neti pots, squirting water up into your sinuses, or otherwise snorting water, it's probably best to use sterile water. Get ready for more Chagas disease. As you probably know, it's endemic across the southern half of the United States. There's a slightly different epidemiology of the disease, but it's now being tested for in blood transfusions, or actually in patients who are donating blood for transfusions. I have my first positive serology for Chagas that I'm in the process of trying to figure out what to do for the patient. There's a study in CID about besnidazole for the treatment of Chagas, and it is apparently quite the toxic drug with debilitating neuropathy and high rates of angioedema. There was also a report of the attitudes of Texas hunters towards Chagas disease. It's really quite remarkable. When they're out in the woods, they have plenty of opportunity for exposure to Chagas, being reported being bitten by the vector, seeing animals that carry Chagas disease, and only a quarter of them were aware of Chagas disease, and many of them participated in behaviors that would increase the risk of acquiring Chagas, such as sleeping in areas infested with the vector and skinning animals barehanded, etc. Increasing surveillance is certain to increase issues with the treatment and epidemiology of Chagas in the coming years. So that brings us to the end of the Puscast. There are 2 reviews out this month, one in Clinical Infectious Diseases on diseases with chronic granulomatous disease, and the New England Journal of Medicine has a review on the diagnosis and treatment of Clostridium difficile diarrhea. I usually just mention that there are reviews out there for your entertainment. Otherwise, the references are available online. My website, of course, is edgydoc.com, where you can find links to my growing multimedia empire. I will be at SMAC in June. I have a book out, The Pus Whisperer, which, if you've read, please go to Amazon and write me a review, only, of course, if you liked it. Otherwise, this is copyright 2015 using the Creative Commons license. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.